بسم الله الرحمن الرحيم. برعاية رئيس جامعة النهرين الأستاذ الدكتور الطبيب علي الشاوي، يقيم مركز الدنا العدلي للبحث والتدريب محاضرة علمية بعنوان COVID-19 Complication a Neuropsychological Perspective، يلقيها علينا الدكتورة معصومة رحيم من بريطانيا. والدكتورة معصومة رحيم هي طبيبة باختصاص طب نفسي سريري، ولديها خبرة في العمل في مجال الصحة العقلية للبالغين والاحتياجات المعقدة وفي أماكن الطب الشرعي، ولديها اهتمام خاص بالعمل مع الاضطرابات التنفسية وإصابات الدماغ المكتسبة، وتعمل حاليا في وحدة إعادة التأهيل العصبي والإقليمية في لندن. وفي عام 2019 تم تعيين الدكتورة معصومة رحيم زائرا خاصا طبيبا لمحكمة الحماية ومكتب الوصي العام من قبل اللورد المستشار، ويتم استدعاؤها بانتظام لتقييم القدرات العقلية بناء على تعليمات المحكمة. وأيضا معنا الدكتور عبد الله حسين البغدادي، طبيب أبحاث مركز أبحاث السكري والغدد الصماء جامعة غراتس الطبية في النمسا، وعضو الجمعية الأوروبية للغدد الصماء وعضو الجمعية الأوروبية لدراسات السكري، وكذلك طبيب مشرف في برنامج جابر بن حيان في النجف الأشرف لمتابعة مرضى العزل المنزلي المصابين بفيروس كورونا عن بعد، ومحاضر ضيف للمتطوعين من غير الأطباء لمتابعة المصابين المعزولين منزليا بالتنسيق مع الجامعات العراقية. وشكرا. تفضل دكتور، أنت ودكتورة معصومة قدموا لنا محاضرة.
بسم الله الرحمن الرحيم، والصلاة والسلام على سادة الخلق محمد وآله الطيبين الطاهرين. السلام عليكم جميعا ورحمة الله وبركاته. This video, part of two sessions, we'll talk about the complication of COVID-19, but from the neuropsychological perspective. I will host today the amazing Dr. Masuma Rahim from UK. She is an NHS trust, and she will talk about in details about the complications which come with the COVID-19, but as from the neuropsychological perspective. This session will be in 4 parts, 4 divisions. The first one will talk about the neuropsychological profile, including stroke and hypoxia. Second one will talk about the impact of cognitive impairment on the personality, mood, and functioning. The third one about the role of trauma. And the fourth one will be as scenarios about patient we saw in Iraq, addressing delirium, depression, poor memory, peripheral neuropathy as a neurological perspective, also chronic pain on its can be as secondary for stroke. Then we'll have also 15-minute as like Q&A part. First, before starting with Dr. Masuma, I will just talk briefly about some studies which showed what type of complications we may face with COVID, especially the severe cases. First one, that many studies showed that there's impact from the virus on the neurodegenerative and the neuropsychiatric diseases. The virus can itself do, and indeed many viruses can do that. They make some damage in the neurons. We saw a lot of cases of peripheral neuropathy. We saw many patients with stroke, some of them as like a hematological problem, some of them neurological problem. Indeed, 3 sides working with this virus. First, from the virus itself. Second, as a result of the drugs itself. Some of them drugs toxicity, especially we have the virus can attack or damage, make some damage in the kidney or in the like liver, which do some disturbance for the metabolism of the medication and its excretion, which increase the toxicity. Also, the interaction between the medications we use now, especially if we talk, especially in Iraq, many patients take medication by themselves without physician prescriptions. Some, because patients visit many doctors and each doctor prescribes some medications, and this can also make some complications or interactions. Also, the psychological aspect of the pandemic itself. We have the lockdown, the anxiety, general anxiety, health anxiety, which also bring many complications. If we talk just briefly, for example, about some medications, corticosteroids, many studies showed that in a dose of prednisolone of like 40 milligram per day, or dexamethasone, which is more potent than the prednisolone, can do itself some depression, mania, agitation, and mood lability or anxiety. This complications is very common now. We saw a lot of patients with delirium, with depression, with even some sleeping disorders. Some of them started earlier than the infection. Some of them start with the infection. Some started post-infection. We'll talk in this in details about this in the scenario part. I will now move to Dr. Masuma. Dr. Masuma, thanks for accepting the invitation, and thanks for being with us. Please.
My pleasure. Thank you for inviting me, and Assalamu alaikum to all the attendees. I suppose when we're thinking about the neuropsychological impact of COVID on people, on people's functioning, we're really looking at a number of different things. So in neuropsychology, we are firstly looking at issues like mood, so depression and anxiety. And we can imagine that for people who have been in hospital for a while, who have maybe not seen their family members, who have been subject to lockdown, and who might have worries about the future, particularly if they have physical impairments, there would be significant levels of depression and anxiety. And so we know, for example, that even in typical stroke populations without COVID, around 40 to 60% of people can become very depressed post-stroke. When you add in the complicating factor of having been potentially very, very unwell in the context of a pandemic, which may have affected all aspects of your life, depression and anxiety are going to be something we see very frequently in clinical settings. Another thing to be very much aware of is a trauma response, some kind of PTSD. And if we think again about people who may have been extremely ill, potentially unable to breathe, they may have thought they were going to die. They may also have had very distressing experiences in hospital. It would be very common for people to experience PTSD symptoms such as nightmares or flashbacks, and to be extremely frightened. And we're seeing PTSD in quite a lot of our patients who have had COVID and who have been in intensive care and who have been intubated. But what we're also seeing is people who have quite significant cognitive changes. And when we're looking at, for example, people who may have had major strokes, maybe middle cerebral artery strokes, secondary to COVID, we will see often very compromised cognitive ability. What is sometimes underdiagnosed is hypoxic brain injury, where there will have been perhaps a significant period of oxygen deprivation, which will have affected neural functioning and which may lead to cell death within the brain. And in a profile like that, what we often tend to see is slightly more subtle downgrading of ability across the cognitive domains. And so even though some people will present with a substantial stroke, despite having no risk factors aside from having had COVID, it's often the people who have more subtle hypoxic injuries who are at risk of being underdiagnosed. But because hypoxic injuries tend to lead to reduced cognitive ability across the domains. So thinking about attention, concentration, working memory, visual and verbal memory, language, visuospatial ability, and the more complex, higher order thinking skills relating to planning, problem solving, decision making, and abstract reasoning. What we're likely to see is a significant group of people who experience downgrading across the domains, which is not recognized as a brain injury. And so because it is not recognized as a brain injury, the patient may be considered to be depressed or to be unmotivated, or potentially, if they're quite withdrawn and disengaged, to exhibit the negative symptoms of psychosis. So it's very important to get a differential diagnosis between discrete mood issues, a trauma response secondary to being extremely physically unwell, and potentially very subtle cognitive impairments. The challenge, of course, is that those things might co-occur. You might be depressed, but also have cognitive changes. And so taking a very structured approach to assessment will be important in differentially diagnosing what some of the potential difficulties might be. What we also tend to see is potentially patients' families not really having a clear understanding of why their relative has changed. So they may understand that their relative has had COVID and been physically unwell, but they may not understand why that person, when they go back home, is not doing the things they used to do. They may complain that the person doesn't speak much, that they spend a lot of time asleep or complaining of being tired. They may complain that the person doesn't do anything for the family. They no longer cook, for example. Or they may describe some subtle changes in personality, for example, people becoming very angry. I think one of the difficulties is because often we think of COVID as a physical illness, as a respiratory illness. There has not been enough attention given to the impact on daily function. And of course, fatigue is going to be a big factor and will play a big part in people's rehabilitation. Because if you've been extremely unwell and in hospital for a significant period of time, and maybe in intensive care, you will have become probably very deconditioned and very weak. So there will be physical fatigue. But because there may have been, as I say, some kind of hypoxic injury or potentially brain inflammation, there is good evidence that inflammation and demyelinating diseases occurring secondary to COVID, you are likely to experience cognitive fatigue. And that will further affect attention, memory, the ability to engage in complex tasks, and processing speed. And so you might get a picture of someone who appears to have made a reasonably good physical recovery, whose breathing is now relatively normal, and who is maybe physically a little bit weak, but where there might be real changes in how much they're able to do, how easily tired they are, and in the way they interact with their family. And because families may not understand that, it is quite possible that they will expect the patient who has had COVID to do more than they are able. And if the person with COVID wants to do what they used to be able to do, but no longer can, that can also lead to further deteriorations in mood. So we have a picture where you perhaps have quite vicious cycles, where COVID has led to reductions in function. The reduction in function leads to a deterioration in mood. And when people are depressed, withdrawn, lethargic, sleeping badly, perhaps not eating enough, what they're able to do then reduces. So it's very, very important to get a good sense of what the changes are, to try to assess for depression, anxiety, PTSD, and do some basic assessment of cognitive function. And to then use that information to explain both to the patient and to their family exactly why the patient is thinking and behaving and feeling the way that they are. And if you're able to conduct that assessment, even using brief items, brief assessment tools, and if you can then use that information to explain it to the patient and their family member, it is likely to make the process much less stressful, and for the patient to be less likely to be blamed for not returning to full function as soon as they leave hospital. And so in neuropsychology, these are the approaches we're concerned with, not purely cognitive testing, but looking at the person's entire presentation, looking at the impact of the changes in their mood, personality, and cognition on day-to-day function, and making sure that both the patient and their family have a good understanding of what that means for them in the short to medium term. Because the reality is that at present, we don't really know what the long-term consequences of COVID will be. And although we are familiar with working with strokes and hypoxic injuries in the general population, we don't know what the secondary complications may be further down the line. And we don't know if COVID increases people's risk of having a second neurological event. And so there are many questions we can't answer. And there is lots of information that we can't give families. But it's important that we give them the information that they need to ensure that things don't break down or get even more difficult when the patient goes home. In the second session on Sunday, inshallah, we'll look a bit more at assessment tools, brief tools, to look for signs of depression and anxiety, PTSD symptoms, specifically in the context of COVID, and basic assessment of cognition, looking at all those domains: attention, verbal and visual memory, visuospatial function, and the more complex thinking skills, as well as language. Because without that assessment, it's very hard to make a differential diagnosis and have a clear clinical opinion on the patient's presentation. Abdullah, I wonder if you have any specific questions on the basis of what I've just been talking about.
Yeah, thanks for the clear explanation. Well, do you think it's more connected with the hypoxia or with the virus itself? as indeed we don't have any studies which explain the connection between them, or if there is any connection with the neurological defects like strokes or mini strokes, as you mentioned previously in one of your emails, which, like you said, some patients may have some small strokes in their brain. Then that's why they need some MRI for screening. What do you think about it? Like, it's more connected with hypoxia itself, and then we can make some connections with other hypoxic diseases, or it's more with viral infection?
Well, I think the reality is that we don't entirely know. I can try to share my screen because there are a number of papers which are likely to be useful. But actually, what I might do, if this would be useful to the attendees, is I can put together 2 or 3 papers which talk about the different presentations. But what we know is that COVID can make the blood almost stickier and thicker. And so even in patients who do not have hypertension, who do not have diabetes, who are not overweight, who do not have any other vascular risk factors, the blood can become sticky enough for it to cause an infarct or for a clot to travel to the brain. And we don't really know the precise mechanisms behind that yet, but we are observing in young, fit people an unusually high level of stroke. And what we're often seeing is middle cerebral artery strokes, which are often associated with very significant cognitive and physical impairment. And so we have patients, for example, in my unit in their early 30s who will have had strokes like this and will exhibit the classic left-sided weakness, and who will be verbally very intact because the left side of their brain has been preserved, but they will present with difficulties with attention to visual detail, for example, and their visual memory will be poor. But interestingly, their insight, their awareness of their cognitive difficulties will be very impaired. And so because they are able to speak, often their difficulties will be underestimated, both by themselves and by their families, and potentially by their treating teams. And that makes these patients quite risky for the reasons I outlined earlier. But what we are also seeing is a significant increase in acute demyelinating conditions, which usually affect children and are secondary to a virus and the inflammation that results. But we're seeing that more and more in adults. So in a recent study published in Brain by the team at University College London, which I can send to participants if that would be useful, they've seen an increase in adults presenting with ADEM-like conditions, an increase of 400%. So they used to see 1 patient a month, roughly, with ADEM in adulthood. They're now seeing roughly 1 patient a week. And that is very significant. And so what we know about ADEM is that the presentation can look a bit like multiple sclerosis because it's demyelinating, but we will see significant changes in all the cognitive domains. So people may present with difficulties finding the right word, for example, which of course affects your ability to participate in conversation and social interaction. But they will also present with reductions in attention, poor concentration, perhaps some visuospatial changes, some motor slowing, quite possibly, and then changes in complex thinking skills. But with patients like this, one of the challenges, if they have some language impairment, is that that really affects their ability to engage in normal, everyday social interaction. It means their ability to communicate with family and friends may be reduced. And that can have quite a significant psychological impact. Because if you are already more fatigued than usual, and if you've been in hospital for a long time and maybe have been very ill, and if you have symptoms of depression, or you're very anxious about your health and becoming ill again, often one of the things that people really benefit from is social interaction and being able to engage with their community. But if you have something like ADEM, or you've had a left middle cerebral artery stroke and your language is impaired, that will mean that you become much more isolated. Because if you can't engage in social interaction, it's very, very difficult to get support. It's very difficult to feel included in your family and in your community. It is much harder to return to certain roles. So if, for example, you have children, but you have such significant language changes that you can't really communicate with them very effectively, or you can't explain things to them, that will really affect your relationship with them. Or if you have an office job and your ability to rapidly engage in conversation in meetings or on the telephone is affected, that will mean you can't do your job as well. And so then people are at risk of losing their roles, of their self-esteem being further affected, and the risk of depression goes up. Interestingly, what we often see in patients who have hypoxic injuries is slightly more subtle language impairments. So people who have hypoxic injuries often, but not always, might recover their fitness, their physical health relatively well, and they might be quite able to engage in conversation. But for those kinds of people, often you see more impact on the abilities associated with the frontal lobe, so the executive functions. And then you're really thinking about people's ability to plan and organize everyday activities. You're thinking about their ability to return to driving or being able to go out independently. They may not be able to manage finances as effectively as they once could. And so if you are the person in your household who everyone relies upon and who looks after the family, and suddenly you're not able cognitively to go out and go to the market and buy the food, or you're not able to look after the household's budget because you keep making mistakes and you can't plan for the future, that again is going to lead to significant change in your self-esteem, but it might also mean that your family, if they don't understand what's going on, might become extremely impatient with you, quite irritable. The chances of conflict within the family are significantly increased if there's not a good enough explanation of why these changes have occurred.
Talking about the role of the trauma, I saw some patients like before the infection, they were for a long time, maybe one month or two, in positive symptoms like anxiety. Then in the middle of the infection, they dropped just for the negative, like strong depression, which take long time. Is it as effect of the trauma or part of the post-traumatic stress disorder or something else? What you can talk about this?
Well, I think that the complexity is that even if people have not been seriously ill with COVID, and even if they have not required hospital treatment, they will probably have been extremely anxious and maybe quite health anxious. And I think we're seeing that globally, that even if people have been able to avoid getting COVID, the impact on daily life of the pandemic has resulted in an enormous increase in mental health problems more generally. If you then have the additional complicating factor of having been physically very unwell, people may well have a PTSD presentation, but they might have something like PTSD combined with health anxiety, for example. And so you might have someone who has flashbacks, who dissociates, who has nightmares, but who maybe also becomes very, very vigilant of the physiological symptoms of a respiratory illness. So it might be the case that they are much more aware of their breathing or their pulse. And it may be the case that triggers like that, feeling breathless or feeling like you're having palpitations, triggers like that may then result in episodes linked to PTSD. So breathlessness, normal breathlessness, which we all get sometimes if we're going upstairs too quickly or whatever, normal breathlessness might become a trigger for PTSD flashbacks. And then you have the complicating factors. And so you can work with the PTSD, but you need to also work with the health anxiety. And I suppose what's important there is thinking about what is the priority for treatment. And that often needs to be decided on an individualized basis, but also thinking about what the resources are for treatment and how that can be most effectively given.
Before the treatments, I want to talk about how to spot some diagnoses. I want to talk about some symptoms or even cases. Although we'll talk in the next session in more details about the assessment, I want to talk about some scenarios we saw or cases, like starting with delirium. Like I had seen many patients with this problem. Some of them other cognitive apparatus disorders, especially old patients. They said we don't. Some of the patient companions or family they called me. They said my father refused to stay in his room. He want to change the house. He never talked with us. He's okay, or even the physician like examined him or her. Everything okay. He's fully recovered, but as you mentioned, like he entirely changed. How can we like spot the diagnosis here about starting with the delirium, what we can comment about it and how to deal with it. Before mentioning that, I want to explain that we talk about Iraq especially here. From one side, we have huge number of daily new cases. Officially, we have those just who making the PCR test about 5,000 per day. Plus, we expect 10 times more numbers who don't do the PCR test. So imagine this huge number every day. From other sides, we have extreme shortage of all the medical supports, and the worst maybe in the psychological part, because even before the pandemic, we don't have a real psychological system working in Iraq. So how, if we talk how to deal with this, with delirium specifically, as a physician, maybe to spot it as I'm the one who deal with the patients.
Well, I think that delirium is very interesting because delirium is extremely common. It's common particularly in older people, but not exclusively. And so delirium is very common post-surgery. It's very common if people have had infections, so urinary tract infections or sepsis. And so I suppose what's really key is that if someone appears acutely confused or almost sort of psychotic following surgery or a stay in intensive care, what is very, very important in the first instance is to exclude any medical reasons. So getting all the medical investigations, bloods and urine, dipsticks done, and having a look at inflammatory markers will be extremely important. And then if you can see that someone's white blood cell count is raised, you can intervene. If it appears they have a urinary infection, you can treat that. And we would then expect the symptoms of delirium to resolve reasonably quickly over a period of days, hopefully. Although, of course, people can have complicated infections and develop sepsis. So I think, it's worth remembering that delirium is very common and that actually up to about 80% of adults who have been ventilated will experience delirium. And then I suppose it's really worth thinking about making sure that people's physical health is catered to, making sure that they have adequate nutrition, that they are not dehydrated, making sure that there is no other risk to their physical health. There are some quite good and relatively rapid delirium assessment tools which can be used by physicians and nurses. And I would be very happy to either talk those through on Sunday in our assessment session, but also to send them through to the attendees with any other papers that might be useful as a follow-up to these sessions.
Moving to maybe the worldwide biggest problem, which is depression. Even now, many countries, not excluding Iraq, like for example, in United States, it jumped from 8% of the population to maybe 38% of population get within the pandemic. Some of them just because of the pandemic or the anxiety moved to depression. Some others even within the infection or post-infection problem. So also how to spot it as a physician, how to deal with it as like first line medics, let's say, with the patients. Yeah.
So how to spot delirium specifically? How to spot kind of long COVID?
Depression. I'm talking now about depression.
Well, I think we often think about the physical symptoms, the biological symptoms of depression as your key indicators. So disturbed sleep, disturbance in appetite. So that might be sleeping too much or not sleeping enough. When thinking about sleep, it's important to ask specific questions. Is it that someone has difficulty getting to sleep at night? Is it the case that they can get to sleep, but they're waking up in the night? Or is it the case that they are waking early? Because all of those are slightly different manifestations. When we're thinking about appetite, is the person eating less than they used to? Or are they eating more than they used to? It's also quite important to think about the psychological factors like hopelessness, about suicidality, about thinking thinking about precisely what some of the thoughts are that are making someone feel hopeless. Is it because they are extremely fatigued and they can't participate in family life, and that worries them and makes them feel guilty? There's a very strong correlation between depression and guilt in most populations. And so it's worth having an eye on those kinds of factors as well. Of course, if someone talks about wanting to end their life, the important questions to ask around risk are around whether they have a plan to harm themselves, whether they have any intention, and whether there are any protective factors. But we're really looking for the biological changes, hopelessness, and also factors around a lack of enjoyment, a lack of motivation, and social withdrawal. Because if someone feels very hopeless, and if they are not getting sufficient sleep or food, it's very, very common that motivation to engage in everyday activities and to engage with other people socially will reduce. So those are the primary questions to ask when assessing depression.
And want to know it is something serious we have to shift the patient for a psychologist, or it is something temporary for limited time. Especially we face, for example, the infection itself may or very common cause like loss of appetite, or like disturbing of sleeping. So how to recognize it and classify it as something easy just to deal with it with some like insuring, and some which is serious, we have to shift the patient for a psychologist or psychiatrist. Yeah.
So on Sunday, inshallah, I will go through some brief screening measures for depression and anxiety. They are 9 and 7 items each. So 9 items for depression, 7 items for anxiety. And that is a very brief assessment. And those screening tools have scores attached to them. And you simply give the patient a score based upon their answers. And then the tool tells you whether they are beneath the threshold for a clinical diagnosis or a potential diagnosis, or whether they meet that threshold. And then if they meet the threshold, that suggests that onward referral may be useful. But it's also worth thinking about whether these symptoms pre-existed before COVID.
Yeah.
Because of course, depression and anxiety exist in the normal population as well, even those who have not become unwell and who have not been affected by COVID. But there are brief screening tools which any member of the treating team can use just to get some sense of what might be going on.
Yeah. I will ask for a few words for 2 more symptoms, if I didn't take the time more than should be, about the poor memory. And indeed, I had many colleagues, many physicians, they suffer now from these complications or like post-COVID complications, although they are young, very active, and they were like in good, even their symptoms, sometimes most of them, or many of them were just mild cases of COVID infection.
So there is evidence that even people who had quite mild symptoms and did not require hospitalization are reporting impaired attention and concentration. And what we know is that if your attention is impaired, your memory will also be impaired. Because if you're not able to attend to information, you will not be able to effectively encode it in the brain's memory stores. So that is one. That is one part of it. Another part of it is that if there is some ongoing physical or cognitive fatigue, it will be more difficult and it will require more effort to effectively remember things. fatigue plays a big part in cognitive function. And the third thing is that when we are anxious or stressed, actually our ability to concentrate, pay attention, and function effectively from a cognitive perspective is impaired, because our limbic system is overactive. We're in sort of survival mode. And the reality is that in the context of a pandemic, almost everyone is significantly more stressed and anxious than they used to be. For people working in healthcare, our patients are ill. We have more patients than ever before. Many of them are dying. We are worried about ourselves and our friends and our family. And those three things together will result in lots of complaints and worries about memory.
Yeah, as a result of activating the sympathetic nervous system, all come together.
Exactly that.
Yeah. Moving to the peripheral neuropathy, indeed, although it is very common with many diseases, especially diabetes, we also face it very like the symptoms come very quickly, like in 2-3 days, the patient starts to suffer from symptoms of peripheral neuropathy, and many of them, even they like have both peripheral neuropathy and some psychological problems. Can it be connected to together with like this physical symptoms with some mental problems or psychological problem?
Well, the link between COVID and the neuropathy is still slightly unclear. What's interesting is that peripheral neuropathy should not usually lead to cognitive changes. And in those cases, it is often a mixture of trauma and anxiety. So often those things occur in a secondary way. If you've been on a ventilator and you don't really remember a lot of what happened to you, that might just be an absence in your memory. But if you remember actually losing sensation in your arms and your legs, and you remember weakness, and you remember falling, and you remember the fear of that, because that is terrifying for most people, often there is a huge anxiety and trauma component in those patients. So although the cognitive relationship has not been established, there is quite a clear relationship between peripheral neuropathy and psychological presentations.
Yeah. Moving to the last symptom I want to talk about, then we will move to the questions part. Chronic pain, which can be as like a result, maybe secondary stroke or something like this, or it is just because of the damage of the like organs, like we have many pleuritis, induced pain. From the psychological part, what we can face due to the chronic pain?
Well, often pain can result, of course, from neural damage. But also, if someone has been in hospital for quite a long period of time, they may have contractures in their legs, for example, which might mean that if they try to move their legs, actually things have all tightened up, as we see often in stroke, for example. So often the muscles become very weak and deconditioned, and that means it's actually just physically harder for people to move. In those kinds of scenarios, physiotherapy is often one of the most effective interventions, because you're looking at improving range and strength. and assessing things like tone, for example. If you've got heightened amounts of tone, that can cause a lot of pain. There are, of course, pharmacological interventions, which might reduce the severity of the pain and enable people to continue with some physical activities. And there are, of course, psychological interventions, thinking about the kinds of activities people want to do, what they're no longer able to do, thinking about prioritizing the most important activities, and then thinking about how they can grade those activities. So start with small aspects of it, monitor their pain, take breaks when the pain gets too bad to avoid overdoing it, and gradually building people's tolerance to engage in activities. There is often a real psychological component to pain. It is possible, of course, for non-psychologists to do that kind of work and to help people return to previous activity in a very gradual, very graded way. But it often requires quite a lot of time to assess and put together a very clear plan of how they will be able to manage that and to review it very regularly. So it's quite a time-intensive approach.
Starting with the questions and answers, so please, for our audience, if you want to ask directly, you can just raise your hand or write in the chat. I will start with one question about the management, although for the questions, I will read it for you when we have something in the chat. But one question about the medications, although we don't have in this part, we'll not talk about medication because we need psychologists, sometimes need physicians to describe according to the case of the patient. But one interesting study, I will share it with you just to hear your opinion. It says there's good effect or high effect in the high dose of vitamin B as a supplement in treatment of psychological problems. Indeed, we use high dose of vitamin B to treat peripheral neuropathy, especially with diabetes patients. 5 days like injections, then the normal dose. This study showed that it's very good, it has good impact, good result with patient with depression due to like work anxiety or work-connected depression or mood disturbance. Can we use it as prophylaxis or treatment, as it is first, it is safe, this vitamin, and also it can be with multiple good effects. What's your opinion about it?
Well, I'm not medically trained, so I can't give a clear opinion on that. But I suppose, like any intervention, as long as there are no contraindications, it may be worth trying. I think also it's important to remember in medicine that although we talk about practice, about evidence-based practice, also there are situations where we try things out, and we see if there's an impact, and we talk about practice-based evidence, and sometimes things are used prophylactically when there maybe is not a huge amount of evidence for them. I suppose in situations where we're dealing with novel diseases, which have complex outcomes which we don't fully understand, I think if as long as the treatments we're offering are as safe as we can make them, and we apply that principle, there may be merit in it. But beyond that, as a non-medic, I'm afraid
So I realize it because it is safe to talk about it as not medication, and also just to have it as we have some spots from the studies. We have a question from Dr. Yasmin Mohsen. Please, Yasmin, unmute yourself and go ahead.
Unmute. Assalamu alaikum. Thank you very much. Both, it was very interesting. Thank you for that. I wanted to ask, my question was about rehabilitation. So I found it quite interesting what you were saying about how we easily focus on the physical aspects and the mental cognitive aspects are harder to see. Are there psychological rehabilitation programs in place for people who have suffered with COVID complications in this area?
Well, Islam, yes, there are. So I work in inpatient neurorehabilitation. And so we have physiotherapists, occupational therapists, speech therapists, and psychology, as well as nursing and medics. And we use a lot of the rehabilitation techniques that we would use with people who have had non-COVID related brain injuries. Because this is what we're talking about, really. We're talking about COVID related brain injury. And so we would often look at someone's performance on formal cognitive assessment, pencil and paper tasks, and then look at their ability in everyday tasks, cooking, going out, planning activities, communication, their ability to perform their job or their roles within the household. And then we would look at a cognitive rehabilitation approach to improving their performance in quite a structured, goal-directed way. So our rehabilitation for people with neurological impairment secondary to COVID is not that dissimilar from our approaches with people who have impairments for other reasons. One of the challenges, and I think this will be a problem globally, is that there will be lots of people who had maybe a mild episode of COVID, or who maybe appear to have returned to quite good fitness, but where there are really subtle cognitive changes. And I think that over the next couple of years, there will be a lot of people who are perceived to be maybe a bit depressed and to be underperforming at work, whereas actually they might have cognitive impairment, a kind of mild cognitive impairment, which has not been assessed. And so they're not going to be getting the support they need to help them fulfill their roles despite those mild cognitive impairments. It's going to be a big challenge, I think, globally.
Yeah. Then, with the shortage of such centers, rehabilitation centers in Iraq, is there some advices we can advise patients to do from some, like for example, pulmonary rehabilitation, we advise patients to make some like 10 times deep breath to walk or something. Psychological rehabilitation, what we can advise patients and their families?
Well, I think there are specific things that can be worked upon. So it is possible to help people to self-manage their pain. And it is possible to help them to self-monitor and self-manage their fatigue, for example. And I think one of the really important things there is to make sure that families are being given information. And there isn't always time, of course, to spend a lot of time with families to give them that education. But it is sometimes possible to put together leaflets, for example, which have the basic information that is useful for families and some ideas of the things they can do that are useful. So helping the person to avoid fatigue, making sure they take breaks throughout the day, making sure that they are supported with certain activities to begin with. These things are all possible. It is challenging when you haven't got a big team of specialist neurotherapists, but it is still possible to give people information and for them to do some of that self-management at home.
I have one request, but it's question, but I'll make it as a request for the next session, that about risk assessment for self-harming and suicide crowds. So I hope that we have it also in the next session.
Yep, that's fine.
Inshallah. I think there's no question from the colleagues. Then I'm gonna finish this session. Maybe you have something to add before finishing the session, Dr. Masuma?
I think that COVID is an interesting and unpredictable illness. And I think that we are only just beginning to understand some of the neurological, psychological, and neuropsychological consequences of it. And over the coming months and years, our understanding will increase. But I think we're looking at something which is extremely complex and which is putting a lot of pressure on healthcare services and patients, but also putting a lot of pressure on us in terms of stress and anxiety. And I think that there is a lot to be learnt. But I also hope that as our understanding develops, we will find much more effective ways to help people with these unpredictable secondary consequences.
I wanted to thank you, Masuma, for your time, for your valuable lecture, and a lot of thanks for our audience, for our colleagues who attend this webinar. Inshallah, we'll see you Sunday at 5 p.m. Baghdad time. Special thanks for Professor Dr. Ali Al-Shawi, the director of Nahrain University, and also for our colleagues in the Forensic DNA Center, starting with Dr. Diya Shamikh and Dr. Rasha Sadiq and Mrs. Dania Mun'im, for all their efforts for open the chance for us to support our colleagues in Iraq. And inshallah, see you in Sunday. في أمان الله.